medical racism also speaks to classism. It also speaks to sizeism, to colorism. You know, it speaks to who can afford these top doctors.
For part 2 of our interview with Sabrina Sarro, a New York-based psychotherapist, we're going to chat more about some of the issues surrounding chronic illness. So those include how to talk with healthcare providers and others. But first up, we're going to look at medical inequality. And I'm really glad you reached out to us about this topic, Sabrina, because it's something that we've been discussing in regards to our own website. And our patient questionnaire data shows us that our community is quite diverse, but the diversity falls short of what you see in the census data for those regions, which implies that we could be doing more. And when it comes to physical symptoms, our patient data shows that ethnicity and country don't have any impact on the person's physical experience. But we know that while the physical experiences might be comparable, other studies show that experience of healthcare is not. It's vastly different for people of color and other marginalized groups. And this has been studied from a number of angles in the US. So I was hoping you could share some insights about the ways in which it is not equal.
Yes. Oh, the topic that I live, breathe, and sleep. Yes. Yes. Thank you. And thank you so much again for having me. Well, let's just start off with the fact that there are very few Black urologists and Black gynecologists in America. Let's just start off with that fact. Yeah, there is a disproportionate amount of Black POC practitioners of color compared to the number of white cisgender men that occupy the territory of urology specifically. And one of the biggest points of medical racism that I personally and professionally can speak to is that most of us do not feel comfortable being with providers that don't understand the larger systemic context of how Black and brown bodies, right? TGNC bodies, intersex bodies, right? Like we have already been predisposed to so much medical torture historically, and I'm speaking through the lens of America, but I know that stretches far beyond, right? Like medical racism isn't just confined to, I said this one racist thing to you in the office that was covert or overt, but it actually speaks to the texture, the fabric, and the bones of how communities of color just already most of us don't generally feel safe entering a doctor's office. Then on top of that, to have specific chronic health issue, and there are studies and links and articles, many of which I've sent you and many of which that you're talking about, all around the board that show the data points to the fact that people of color experience more chronic pain. We are in pain more. We experience more pain generally, right? We're living in a state of warfare constantly. So our pain receptors are much higher, and then coupled with chronic conditions that are misdiagnosed, undiagnosed, that just creates an entire cocktail of pain reverberated throughout the body tenfold. But in regards to medical racism, it can look like anything from a doctor's condescending tone to you that you notice they don't give to a white person. It can be anything from somebody asking to make sure your credit card is on file several times when you don't notice that they're asking a white person to do that, or maybe they only asked the white person that one time. It can be anything from medical providers, and medical providers have told me this, that I'm inflammatory, angry, that I'm being divisive, or that I'm asking for too much, or that I'm demanding too much, right? That's medical racism. That's somebody putting me in this angry Black person trope, when in actuality and reality, I'm trying to get exactly what I came for and exactly what I'm paying for. That's that, so it can be small things, which are not small, but things at the granular level, like, not knowing how to handle a Black body, not understanding the compassion, the competence, the sensitivity, the warmth, not knowing what that comes with, right? And you don't need to be a Black provider to lean into that. Like, one thing that I always joke with my colleagues is like, doctors need to be trained in what empathy is. What is radical empathy? Yes, like I don't see that often. I don't see that. So,
Yeah.
and then, even with pelvic floor physical therapy, right? Like somebody's hands ostensibly are manually inside of you in some way or another. Warmth, compassion, creating and curating a safe space, right? Like Black bodies historically have already been poked, prodded, have been used, right? Like we can reference Henrietta Lacks. We can reference so many Black bodies whose bodies have been used in the medical industrial complex to either find things out, La Operación, which talks about birth control and indigenous bodies being used, as experimental to trial. But there's a whole history. And I feel like medical school in general, I don't know if medical school is talking about those histories. I don't know.
I doubt it.
Doubt it. I feel like they get one course on what it means to be culturally sensitive, and that's that. And so like medical racism also speaks to classism. It also speaks to sizeism. It also speaks to colorism. It speaks to who can afford these top doctors, who can afford insurance that will even cover a urology. Oftentimes urology and urologists are considered specialists. Does Medicaid, does Medicaid, like for people who are on public insurance, how do we help them get access? How do we support them with things like microgyne or pathnostic? Like just there are all of these things that then become about money, access, who can get to where, who has a support system where, who has a therapist, who has a partner, who has people that can hold them down, right? And historically, communities of color do not. We live in poorer areas. We have access to lower quality food. We live in areas that have worse air quality. We live in states of genocide every day. And speaking as a New Yorker, speaking about police brutality, which one might not necessarily make the link between medical racism and police brutality, but when you're already living in a heightened state of fear as a Black person, where you might get shot just for existing down the street, or when that's all that's infiltrating the news, and you're trying to just get to a doctor's appointment where somebody can treat you with some compassion and warmth, yet you're met with the same sterile slap or the same, well, we can try this, and I've sent the prescription to your pharmacy, and come back in 6 weeks for a follow, right? Like there's just no fullness in the world of, there's no emotional fullness that I've rarely seen in this world, and that speaks to medical racism. It speaks to how we're erased, we're negated, we're invisibilized, and like I never see Black people. It took me years to even see a Black fetus in a science textbook.
Yeah.
We often see white babies, white fetuses, white bodies, right? Like I don't see any Black people being advertised for IC, for UTIs, for I don't see that often. I hope to God they're out there, but I personally, as a Black person in the field and suffering, I don't see anybody looking like me.
Can you talk a little bit more about why representation is so important and how it links to not feeling alone, which is such an important part of the chronic illness journey?
Yeah, representation matters because we are looking for our kin. We are looking for the people who look like us, who can ostensibly understand the cultural, systemic understanding of what it is to be moving through these spaces in America right now. Representation matters because we deserve to have practitioners and providers that can look like us, empathize with us in a very distinct and different way, and who also can hold us down in a different way, right? Like on the few occasions that I've met with a Black provider and it went well, I felt like I hit the jackpot. Like I felt like, wow, somebody gets it. Somebody's answering my questions. Somebody's not pushing me out the door. Somebody gets how hard it is. Like being outnumbered in these fields, right? Somebody gets what it means to like the vulnerability of being in a Black body and going to the doctor. That we can have a whole thesis on just that. Yeah, like the vulnerability that it takes to walk into a doctor's office and to ask for support and ask for help when we are so conditioned to either be dismissed, to be told to lose weight, that it's our BMI, right?
Yeah.
To be told that it's obesity related, to be told that it's our fault, it's our diet, to be told that, right? Like, and I, something that I personally notice is just the body language that is given to people of color versus white patients. The respect, and a lot of people are like, Sabrina, how do you know that? Or Sabrina, I've had arguments with doctors where I've called them out on being racist to me. And they were like, well, I didn't say anything. And I was like, you don't have to say anything to be racist. I'm telling you as the patient, you're talking to me in a very specific way, in a condescending way. And while it might not be an overtly racist statement, it is padded and it exists within the larger body of how doctors think it's appropriate to talk to people of color any old damn type of way. And I'm not saying that white patients should be spoken to that way. I'm not saying that at all. Everybody deserves to be spoken to respectfully, but it's the cultural context that people are missing. It is the historical context that people are missing. And I had to do that with my own physical therapist a bunch of times. I was like, listen, a Black person got shot today. The N train nearly blew up this morning. Your hands are inside me, and I need you to talk to me with a little bit more respect. And I need you to understand the weight that Blackness carries. Even though you're not Black, I need you to come outside of yourself for a minute and offer a molecule of empathy and come correct, and like that is often like, and people are like, oh my God, Sabrina, you say that to your doctors? And I'm like, yes, because what am I paying for? To be disrespected for 45 minutes while your hands are inside me? Absolutely not. Yeah, and I think it's just this other layer of compassion that I don't see doctors really leaning into. Right? Like I've been told that like my anxiety is crazy, or like my anxiety is making my symptoms. And it's like, no, I'm just fearful because I'm in this Black body and y'all will kill me. You'll have no problem with me dead. So I have to advocate for myself. And we see this routinely.
Some of the studies that you and I have been looking at demonstrate this too. The study in particular about racial bias in pain assessment and treatment. Actually. And I also, another one that you sent me, it extends to children. And that's even more terrifying somehow because children cannot advocate for themselves. But can you talk about how that bias in pain assessment applies to people with chronic illness?
Yeah, well, I think there's just general understanding that like we don't feel as much pain, or like our pain can be more easily written off, or like, we can handle so much, like we're this resilient peoples that can handle so much. And we are, but when it comes to the chronic, or when it comes to the assessment of chronic pain and diagnosis, I see people taking white pain so much more seriously. And in those articles, another thing that like really sticks with me is just how easy it is for medical providers to discard of the Black body, right? Yeah, like I see, and this goes into like lookism and colorism, right? Like I often think if I was a thinner white white woman presenting person going to see a doctor, would my chances for a diagnosis fare better for myself? I don't know, right? Like, so I
would say yes.
I would say yes, absolutely. If I was a white, oh, absolutely, 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 absolutely. Now, that's not to say that I'd have a diagnosis, because I know.
Yeah, that's unlikely in a lot of these realms.
In a lot of these, regardless of race, urology, it doesn't discriminate, but it still does. And that's the point. Yeah, my point is that if a white, thin, pretty woman can't get a diagnosis, What does that mean for a dark-skinned, Black, trans, fat person walking into an office?
How
What is
can someone advocate for themselves in that situation? Or is it more important to find someone that represents what you need in a clinician?
Yeah, I think it's a combo of both. I don't know too many Black trans urologists out there. I don't even know Black urologists out
Yeah.
there, let alone people who are gender variant or who are on the gender spectrum. But I think, yes, going in and advocating for yourself. And this is why I mentioned psychotherapy being such a
Mm-hmm.
crucial ligament in a person's toolkit, because that's what I often do with my patients. We sit down and we go question by question. We go question by question and we prepare. Like if we feel like a provider is dismissing us or like, oh, you're making that up, we also practice like saying, oh, actually, the way that you just spoke to me didn't resonate and it actually doesn't make me feel safe as a patient in your care. I really appreciate that when I'm asking you questions, instead of speaking in a more flippant manner, you give me the science-based evidence or
Mm-hmm.
your reasoning or what you learned in your 10 years of medical school as to why you don't think this is a possibility. And like we will practice ways to respectfully defend ourselves.
That
And
kind
so,
of lines up with some of the questions that came in
yeah,
about how to speak to a clinician when you bring forward alternatives to what they're suggesting and asking for backup information. That can be really difficult for a patient. It doesn't feel like they're in a position of power.
and it can feel scary. And
Mm-hmm.
so that's why I say, like, you know, if people don't feel safe saying it directly to the practitioner, sometimes I'll advise writing it on the portal if there is one. And if the provider doesn't respond, calling the office and saying, hey, I'm a patient of so and so. I had asked them these questions of concern. Nobody
Mm-hmm.
has gotten back to me. And it's really not making me feel valued as a patient in your
Mm-hmm.
practice. Right. And so, like, if the facial proximity is too much, sometimes we'll practice ways to make that feel safer. But all in all, I always encourage my clients to bring somebody with them if they can. And I know that's been really hard in the pandemic, but
Yeah.
I always have my partner on the phone with me. And providers will be like, are you on the phone right now? And I'll be like, yes, I am. I am on the phone. You know, or sometimes I'll have people be like, why are you on the phone? And I'll be like, because I want to be. Like I'll have providers get a little scared sometimes, and I'll be like, I'm not doing anything. This is my support team right now.
Yeah.
We're all listening to what you have to say because we've nearly died getting to this point. So, I want everybody up in my care team listening. Like, why don't you think this is a reality? Why don't you think this can happen? Why don't you think this is feasible? Why do you think that it's likely not to be an embedded UTI, right? Like, these
Mm-hmm.
are all the things that I've heard providers say to me, and it's like, okay, I want to know. You told me I had squamous metaplasia. What does that mean?
Mm-hmm.
Notepad.
Yeah.
Yes, or and then providers might say, oh, well, it's, and I'm like, no, 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 no. What does that mean? Give me the article, send it to me. You told me you found this, but you're not saying a whole lot about what it is. It doesn't even sound like you know all that well. So, right. And that's not a slap to a doctor, but it's like, this reinforces that we need care. We're in fields that ambiguity is already
Mm-hmm.
front and stage. So it's like, I really need you to come with some compassion and care. If you don't even know and I'm the one in pain, then we gotta sort of work together a little bit. Like, I need to tell you, okay, well, I researched this on my own. Can we try this? And that's something that I'll do. Sometimes
Mm-hmm.
doctors will tell me, all right, this is what it is. We don't really know. And I'll be like, all right, I'm going to do my own research and then bring it to them next time and be like, well, I found this study and it said that this treatment might be possible or might be effective. I want to try it.
Do you think there's a good way to present research to clinicians? Because a lot of people in our community try to do that and find that the response is sometimes condescending.
Yep. I'd say, a big tip that I always use is, again, really reinstating that you are the patient and that their job is to work with you and not against you. And
Mm-hmm.
so, I will often sometimes bring up research or bring up studies that I've read. And yeah, doctors will laugh at me or they'll say, you've been in Google too long,
Mm-hmm.
or they'll say
Classic
stuff like that,
response. Yeah.
right? They'll say, like, you're losing it, they'll make some sort of gesture or face to me, and I will remain very firm, and I'll say, I don't like that you just did that. That didn't make me feel cared for. That didn't make me feel respected.
Mm-hmm.
This is research out there in your field, and I'm bringing it up to you because I'm still in pain.
Yeah.
And I'm desperate, and I want to try this. That's what I'll say. And I'll say it respectfully, but I think a big part of advocacy is learning how to tell your doctors that they cannot talk to you any old type of way. They can't. And, doctors think, right, there's elitism around that field, right? And I think like doctors typically, from what I've seen, don't want to be confronted with the possibility that they might be wrong or that an alternative point of view might exist. But I will simply just be very calm and say, well, here are the facts. I've been in your care for X months and I'm not any better. So this is what I've researched. This is what I've learned. This is what I've heard from other people in the community. This is what I'd really like to give a chance. Can you help me with that or not?
I think most patients understand that it's impossible for a clinician to be up with everything that happens in research. What they want is for them to be open to reading new research that they bring, with the understanding they don't expect them to have known in the first place.
Yes, exactly. Like, are you open to listening to what I researched? I researched this, I found this. Can you help me with what I am presenting to you? Are you willing to consider these perspectives? And I think
it's a tough conversation for sure.
It's really tough. And that's why like having a therapist or just having somebody in your corner can be so monumental and so life-changing, just in the way that like that can really help someone feel stronger, feel more empowered, feel safer to actually just state the truth. Like I think we get so gaslit into thinking that like if we question a doctor, that's disrespectful of us, or like we're wrong to do that. And it's like, no, like any other provider you might see, if something's not working for you, we can practice saying it so that we can set ourselves up to get the care we really want and really deserve.
Agreed. There was other questions around these types of conversations, but some of them were actually about the workplace. And a lot of people are afraid to bring up their chronic illness in the workplace because it might mean they're passed over for promotion or that their work is undervalued and they're not certain what they should and shouldn't mention. Do you have any advice around those kinds of conversations at work?
Yeah, absolutely. I'd say like it really depends on what the culture of the workplace is and what are the virtue points and value points of where the person is working. But something that I like to do if I'm feeling like my boss or whoever I might be working with isn't going to understand, or if I'm afraid that they're going to think I'm no longer useful to them, or that like, right, like I can't be of service to them, I'm losing, because I think that's a big sort of cloud of fear that also enters people's psyche and body space when bringing these conversations. Like something that I like to do is say what I feel comfortable saying in a way that kind of places the emphasis back on what they claim their mission statement to be. So like something that I've done is, like in regards to your mission statement, which I know really centers disabled bodies and is valued on XYZ, I actually want to disclose that I've been dealing with some chronic conditions myself that I am in the middle of moving through, and that I really I'm really asking and requesting support during this time and ways to accommodate me so that I can continue to contribute as meaningfully as I have and want to continue to do in this position. So I think like really framing that like you are an asset no matter the condition of your body. You are meaningful no matter if you are in chronic pain. You are still someone worthy of a job, worthy of being paid, worthy of having respect, and worthy of being accommodated no matter what is happening to your body. And so I will typically kind of coach my clients depending on what they share with me around, the overall energetic energy, the overall emotional energy in the workspace, and then sort of go from there. But I think like disclosing what accommodations can happen for you. And I know this might not always be accessible given the boss or the hierarchy of what's being presented at an organization.
Mm-hmm.
But I think like really prioritizing your health and demanding and requesting respect and equity is huge and paramount, and something that right, like we have discrimination laws. Right, yeah, like, and I know like some states are at will, they can just sort of fire you for no reason.
Mm-hmm.
Medical discrimination, medical racism, still
Mm-hmm.
capitalism. But I would say, like, I always want to ask, like, what are you comfortable disclosing? Like, you don't have to use XYZ language. Do you want to use another type of language that somebody might be more sympathetic to, right? And like, I never want to encourage people to like lie or
Mm-hmm.
not say or not feel safe expressing the full bodiedness of what they're experiencing. But I know, like, going up to your boss and saying, I actually experienced recurrent UTI and I might need to be using the bathroom. My office might need to be closer to the bathroom so that I can access the like, I know sometimes people laugh at that.
Mm-hmm.
People think that's a joke. People don't even understand what recurrent UTI
Yeah.
is. They've never heard of embedded UTI. They don't even interstitial cystitis. What's that? Does that mean you have cysts? Right? Like, that's something that I hear often, right? Or like, yeah, and like, so I also respect and am an advocate for however the person feels comfortable explaining this or wanting to share this
Mm-hmm.
in whatever small drop way they might want to begin with. I advocate for that. Or like, sometimes people don't feel comfortable bringing up the letters UTI at all because they know people are going to laugh at that. So sometimes we'll play around with language, like, oh yeah, I actually suffer from an inflammatory bladder syndrome similar to IBS. Right? Like, or people know what IBS is, right?
Yeah,
And
they
so
do.
like, people know that, people know what Crohn's is, people know what ulcerative colitis is, right? And they, we see which conditions get more respect than
Mm-hmm.
others. So sometimes I'll be like, all right, well, just tell the person you have IBS. It's not your bowel, but it's your bladder, right? Like, I
Yeah.
see kind of like an IBS, right? Or
Mm-hmm.
or sometimes I'll say, okay, do you feel more? Do you want to just say you have an inflammatory condition? Do you want to say you're immunocompromised? Like, sometimes we'll just play with like what makes you feel better, and to not cower or waver in the face of what you deserve. Like, you deserve to receive accommodations that you want. You deserve the respect that you want, and you deserve to be heard and accommodated, because what is happening to you is not on you and it is not your fault. And
Mm-hmm.
that is something that like I reiterate to my patients as well. Like, here's a way to really like advocate, have a conversation, bring in a coworker that you're really close with, right? Like, you you have the right to have what you want happen for you. And there are ways to like skillfully navigate if you feel like you're in a workplace that's more hostile or
Mm-hmm.
less understanding, less empathic. And then, that might also offer a larger conversation into, do we want to keep working here? Like, do we want to actually find you a job that you don't have to have anxiety about whether or not you have to disclose a chronic health? Do you want to work remote? Do you want to work in your home? Do you
Yeah.
want to, sometimes I'll do that with my clients. Like, actually, maybe this is a bigger discussion into, while we navigate this, let's on the side get you out of here possibly, because it's clear that there's a gulf between what this company purports to be doing, values that they purport to be standing by, and what they're actually standing by. So
Yeah.
I think like that is also like a way to be like, oh, that's interesting, because your mission statement really prioritizes disabled or chronically ill or whatever. And it's quite interesting to me that in this moment, you're telling me that these accommodations
Mm-hmm.
are possible. So I think like really bringing it back and putting the onus on them, because
Yeah.
they're gonna be all right. It's us, right? They're sleeping fine. Yeah,
Yeah.
like it's us. It's us that are navigating pain. So I always really
Yeah.
encourage people to grab at what you want. You are not being selfish. This is your birthright. You deserve respect, equity, whatever you need whenever you're in pain. Like, this is not a novel concept. It is your birthright. Yeah.
This kind of brings up the topic of invisible illness and invisible pain and the trauma that people have in these conversations when they're not believed. You can't prove that you're going through this. Nobody can truly understand it unless they've experienced it themselves. How can someone cope when the result of a conversation like that is just disbelief?
Yeah. I think to remember that, like, this is not all in your head, to really go back to like the core principles of what you've been experiencing. Like, this is not an invention. This is not fiction. You did not conjure this out of thin air. And people will do the most to convince you otherwise, to convince you that, this is made up, or just stress less, or right, or maybe it's just you're eating too many acidic foods, right? Like, or drink cranberry juice, right? Like, we'll hear
my favorite,
right? We'll hear the assortment go on the list. And I think, like, to really remember that, like, you are rooted in your reality, and your reality is not a fiction. You have suffered, you're suffering. You're not going to be bound by that suffering. Like, there's going to be people to hold you down and get you through it. But, like, to really remain rooted in, no, I'm intuitively connected to my body, and I know something's wrong because I spent X years not feeling like this, and suddenly now I'm feeling like this. So, or I've spent my childhood feeling like this, and suddenly now a symptom took a detour and I'm feeling like this, right? Like, so I think it's going back to what I had mentioned earlier about what I like to call the pedagogy of body intuition, and what it means to actually intuitively lean into self, and to know very intimately and connectedly, no, I know my body. I am the expert on my body, and I can tell you very clearly something is amiss. Something's not right. It's burning me when I pee. I can't have sex. I'm going to the bathroom every 10 minutes. That is not an invisible illness. That is a real thing happening to my body in real time right now. Yeah, you cannot invisibilize the truth. And I think, like, really remaining rooted, vision boards, just having a coliseum of people to really support you and just advocate, hold you down. Like, no, we get it. And this kind of reminds me of other invisible illnesses like fibromyalgia or whatever, there's just chronic fatigue syndrome, or just any constellation of complex, chronic regional pain syndromes. I think, no, people are suffering, and you'd know it too if it was happening to you. And that's something that I always tell people.
Yeah.
The fact that you could even say this is an invisible illness really speaks to your privilege, and to the fact that you won't ever know until it happens to you.
Comes back to that lack of empathy that you mentioned earlier. And there, you mentioned a support network too. So I think it's nice to come back to psychotherapy here at the end of part 2. But we talked earlier in part 1 about how important it can be to have that psychological support, even if you are going through a physical treatment journey. But a lot of patients feel like having a primary care clinician bring up mental health support is mistargeted, when they should be providing physical treatment for their physical problem, and that they should deal with the physical problem before dealing with the mental health side of things. And is it even appropriate for a primary care physician to suggest mental health support?
I think it is, but it really depends on how they are posturing that to the patient. Like, I don't think it should be done in a way like, because I've had providers being like, I can't manage your anxiety. You need to see a therapist. And it's like, I don't need to hear that in that moment. The reason why I need a therapist is because you can't diagnose me, right? And that's not to point fingers or to point blame, right? Like, nobody's a miracle worker. I'm not saying that, but I think it's the way that the physician is posturing that. Like, if the physician were to look at the patient and say, hey, I know that right now it's scary and we don't have all the answers. I know that right now you're in pain, and that is a pain that is real and is happening to you daily. I know that I am going to do my best on my end with all of the tools I've gathered to support you and to help you get closer to the answer. And I also think that until we get there, because this might take a while. A therapist might be a great person in your support journey, in your healing journey, to really help root you and ground you in the emotionality of this, which is real and scary and can be just as debilitating as the physical pain itself. And I think if a provider postured that to me, I'd be like, yeah, you're absolutely right. Thank you for affirming both things. But what I think typically happens is that physicians are like, yeah, get your anxiety worked on and maybe that'll help things. And it's like, I think that's where a lot of people feel like, oh, right, like they're taking this is a segue to not really go as hard as they could on my physical symptoms, and like, yeah,
blaming me for my symptoms, which is
exactly, or
how it often feels.
yes, blaming me, telling me that it's in my head, right? Like that it's just my emotionality that's dysregulating everything. And so I think, again, this speaks to competence, sensitivity, and I don't like the word competence sometimes because it can be ableist, but what I mean in this context is having the knowledge and understanding that the way you talk to people makes a world of difference for them. The way you talk to people, the tone, your face, your facial movements, the tonality, the volume, the eye contact, the warmth, the way you speak to your patient can make a world of difference. Like I see one physician now and I love the way she talks to me. I might not be getting better yet, but she talks to me like a person, and that is why I continue to see her.
It makes a huge difference.
It makes a difference. Yeah, bedside manner, instead of being like, oh, you're trying to find trouble where trouble doesn't exist, or like I've heard so many things to me,
so many of us have.
So many, or like, why are you back in my office? Like I've heard so many things like that, and it's like, well, clearly I'm back in your office because I'm still in pain. You understand that? And sometimes I'll have to ask providers, do you understand what I'm saying? Because they talk to me like I'm just dead already sometimes, and I have to literally say, you want me to restate what I just said for you? You want to restate back to me what I just said to you? And I think that's a perfectly fine thing to do, to make sure your provider is getting it. So, back to your point about therapy, I think it's really the way the doctor postures that, because I do think therapy can be life-saving, and not in a way to make the person feel like it's all in their head. Just think of it as a care support team. Like your therapist is not there to convince you that this is all in your head, but your therapist is actually there to help hold you in between the appointments, help get you to other appointments, help you with the grief, the sadness, the good days, celebrating the good days, sharing to somebody about the good days. Like whenever I have a patient text me, I had pain-free sex, I'm like, yes, like I am sending all the clapping emojis, right? Like I'm like, sometimes you just need somebody in your corner that gets it, that can lift you up. Yeah.
Given that most clinicians don't work with therapists or have anyone that they can refer patients to, how can a patient find a good one on their own?
That's the problem. There's not so many of us specializing in pelvic pain. But I'd say like joining the different Facebook groups, Googling, and Facebook groups meaning if the person has access to Instagram or Facebook or any social media, embedded UTI groups, IC groups, vulvodynia groups, pudendal neuralgia groups, Googling, going on places like Alma, Psychology Today, inclusive therapists, trying to put in buzzwords like chronic illness. All of my profiles say IC, UTI, all of that. So I try to make it abundantly clear on my profiles, but I know very well that it's hard for people to find me and to find people like me. And that in fact, in the world of psychotherapy, this is very new. Like I'm trailblazing this. And, there are sex therapists who are trained and equipped in painful sex and endo and chronic illness, but I don't see many people who have direct specializations or trainings in UTIs. I see the bladder primarily. I see more about the vulva and the vagina. I see less about UTIs. I see more about yeast, BV. I don't see a lot about people talking about the relationship between hormones and UTI. I don't see people talking about HRT and UTI,
Yeah.
PG&C people and UTI, right? Like, so I see sex therapists and they're wonderful and they have deep knowledge, but there's still a huge gap.
Yeah.
Yeah.
Hopefully things will change.
We're going to change them. Yes, we are. Yes. You're changing them with this amazing website right now that you've spearheaded. And, you know, my hat is off to you. I have learned so much.
No, thanks. I'm glad that you found it helpful.
Right? Seriously. And, you know, I'm ready and I'm not backing down for our peoples.
Excellent.
Yeah.
Well, thanks so much for sharing your insights with us today. It's been really
so
helpful.
much, Melissa. Thank you so much.